Hi, folks. Just wanting to know if you can hear me, attendees. You can type in the chat box. Can you see my slides? Kirti, if you could just tell me if you can see my slides in the chat box. We'll be starting at 7 sharp. Just a few more minutes, giving a few more of our colleagues some time to join. So I'm going to make a start, everybody. For those of you who know me, know that I'm usually very punctual with time. As a first, I'd like to welcome you all to today's webinar. Today's webinar is the last session that we're presenting with regards to a 3-month course that we've been running on lung ultrasound and neonatology. We've had about 35 participants who've joined us since January, who've actually been going through approximately 17 competencies for learning lung ultrasound and neonatology through this online course. And what I'm going to do is basically give you a little bit of a flavor today of how you use lung ultrasound in neonatology to help diagnose and manage pleural effusions. So as a first, just a little bit about myself, some conflicts of interest to declare. So I'm the director of the MPROvE Academy. We're a not-for-profit organization who basically runs a large number of educational courses globally. We're based in the UK, but we deliver courses on neonatal simulation, human factors, and point-of-care ultrasound. In addition, I've done a lot of work in simulation. I have worked for a company called Lifecast UK and have helped them in mannequin development. Again, this is pro bono work. I do not charge or take any money for this particular purpose. I am a member of the Aspiric Simulation Working Group and a certified simulation instructor with the Society of Simulation Healthcare. For those of you who know me, you would probably know that I have a special interest, in particular, a lot of interest in human factors neonatal simulation and point-of-care ultrasound. Now, what I'm going to talk to you about today is the use of point-of-care ultrasound in the diagnosis and management of pleural effusions. This is a topic that's quite close to my heart because, as you know, the management of pleural effusions often involves us needing to do procedures which involve either tapping or drainage of the pleural effusion through the passage of chest drains. Now, the use of chest drains is not without complications, as we will discuss today. And one of the areas of emphasis that has recently come out is that if you use lung ultrasound or ultrasound per se in trying to manage pleural effusions, not only are you able to diagnose pleural effusions and manage them better, but you can actually reduce the rate of complications that you see. There's a lot of other information that we will talk about in today's webinar. So as a first, how you diagnose pleural effusions, how you quantify them, how you measure them, and then in particular, how you differentiate exudate from transudate. Now, I'd advise a little bit of caution in this when I go through it because it's not as easy as it seems on ultrasound to be able to do that. And biochemical analysis eventually, in my mind, is the gold standard still. However, one of the most important aspects of my discussion today will focus around how you use lung ultrasound to help with therapeutic thoracentesis. And I think for me, that is something that I feel at this particular point should be mandatory when you're trying to manage a pleural effusion, because it helps you in a large number of ways. Now, as we know, pleural effusions are fairly, I would say, uncommon in the neonatal unit, but we see them. And when we see them, usually from our perspective, they can be quite significant, as you might see in the case of mnemonic pleural effusions, which are usually exudative and occasionally present with pus-like findings. But the more common presentations that we see in particular with term neonates are as transudative pleural effusions and non-immune hydrops and chylothorax. And often these are antenatally diagnosed as part of a diagnosis that is by ultrasound able to demonstrate fluid in the intrathoracic cavity of the fetus. What I would like to emphasize is that over time, what we've now understood is that you can actually see pleural effusions with a large number of common neonatal conditions. I would say that about 18 to 20% of babies with RDS actually present with extremely small effusions. And I would say a slightly smaller proportion, about 10% of babies with transient tachypnea of the newborn can present with effusions. What is quite interesting is that the diagnosis of meconium aspiration, when you see it on the X-ray, actually rarely presents with pleural effusions. But it's quite interesting how many times I've actually picked it up while I've been doing lung ultrasound in practice. Now, Why and what is the kind of background for the use of lung ultrasound in diagnostic radiology for detection and management of pleural effusions? Well, I think the first thing that I would like to say is that there are a large number of situations where often when we review chest x-rays, we don't see effusions at all. And really, when you do the ultrasound, you're able to detect small pleural effusions. Now, a lot of people will argue that they're small and they're not going to cause symptoms. So what is the clinical significance of actually being able to do that? And my argument would actually be that there are certain conditions which evolve. In particular, if you look at babies who might have secondary thoracic duct injury, who develop respiratory distress, often X-rays may not be able to pick up small amounts of chyle which are accumulating, which an ultrasound would. What is known from the literature is that, to detect a decent pleural effusion on a chest X-ray in an adult, at least, you need about 150 mils of fluid. But an ultrasound can detect as little as 5 to 10 mils, and even smaller quantities, I would say, in neonates. In terms of how accurate lung ultrasound is, well, a study that's been performed in Europe on 116 adults shows a sensitivity of about 93% and a specificity about 83%, which is much higher than chest X-rays, as I will go on to demonstrate. I think the key thing that I would like to emphasize as part of this talk is the fact that an ultrasound can be done bedside with minimal handling of the baby in a very short period of time with a very reduced amount of radiation exposure. The diagnosis of a pleural effusion, without doubt, has good inter-observer agreement. But from my perspective, in a symptomatic baby who might need treatment, it allows real-time therapeutic management. So not only will you be able to diagnose the pleural effusion, but you can actually do a needle thoracentesis, as well as do a pleural drainage or insert a chest drain under ultrasound guidance to make sure that you're actually doing it safely in the maximum pocket without actually injuring any of the surrounding viscera, in particular the abdominal viscera, because we often go quite low and in the posterior lateral part of the chest. So there are definite advantages of using an ultrasound over just doing chest X-ray, which I think from my perspective have become apparent over the last decade. I think if we look at the evidence for it, so it is now internationally endorsed. So the European Society of Pediatric and Neonatal Intensive Care has actually given recommendations on how to use point-of-care ultrasound to diagnose and manage various respiratory conditions. And there is strong agreement from a group of 40 experts who gathered as part of the committee on this and reviewed the evidence to say that actually not only is POCUS helpful for detecting pleural effusions, but actually it's also helpful to guide thoracentesis in neonates and children. The British Thoracic Society has actually gone a step further, and they actually say that it should be done mandatorily if you want to drain a pleural effusion where time permits and the baby is not an extremis. Now, if I talk about benefits, well, we talked about radiation exposure, but I think there are benefits that we can get from ultrasound that a chest X-ray would not be able to tell us. And in particular, one of them was the fact that we can identify small effusions. But more importantly, alongside small effusions, what we are able to do is able to look at the lung pathology and differentiate a variety of different neonatal lung conditions. So the appearance of pneumonia, and I'm going to show you photographs today, along with a pleural effusion, can be diagnosed and can give you a clue as to the nature of the pleural effusion, especially if you're trying to look and differentiate whether that's an exudate or a transudate, or in particular, if you're trying to decide whether you want to tap that for a diagnostic parasynthesis. We now have good evidence from work that's been done in children and adults that you can actually quantify and measure pleural effusions. There is a very good piece of work which has been done by Balik and his colleagues, and I will actually talk about how you can use that in neonatal practice today to try and quantify how large a pleural effusion would be. You can help with procedural preparation to identify the best site in which you might want to tap or insert a chest drain to drain a pleural effusion. More importantly, I think from our perspective, you can verify which site. Now, in particular, when you have a baby with hydrops fetalis, X-rays might show severe pleural effusions with whiteout, but an ultrasound would actually be able to quantify which of those sides on ultrasound shows a larger fluid collection and might actually be indicative of the side that you want to tap first to produce therapeutic benefit in a baby who might actually be an extremis. So huge benefits there. For me, I think one of the important aspects of using point-of-care ultrasound for pleural effusion is the ability to identify not just the largest pocket, but also to be able to identify the viscera beneath that, in particular the liver on the right and the spleen on the left. And I would say that landmark-based insertion of chest drains is not without risk. I'm going to give you a simple example of a situation that I've been in with a baby who had a large subphrenic collection with quite significant hepatomegaly, where luckily we'd done the ultrasound and we were able to identify that there was significant eventration of the diaphragm along with a significant pleural effusion. And I think if we'd tried to insert a drain in just going by landmarks in the 6 space, we might have been in a lot of trouble. So again, there are benefits in being able to identify viscera, conditions that might be associated, which means you might need to modify the way you're doing the procedure. But I think for me, the other aspect to it is you can actually therapeutically tap under ultrasound guidance. And I'm going to show you imaging today, which actually shows how useful it can be in not just being able to clinically correlate with symptoms getting better, but also if you're doing a diagnostic or a therapeutic parasynthesis, how you might be able to actually prevent lung puncture, especially if you're using a butterfly needle for the process. I think without a doubt, one of the biggest benefits is in being able to identify and manage loculated effusions. And again, I've been in a situation in my neonatal unit in Southampton where I've put a chest drain in for landmark-based pleural drainage, where I've been unable to get an accurate amount of fluid, which I clinically thought I would. But getting an ultrasound done actually helped me identify a loculated pleural effusion with the maximum loculation superior to the area that I was going. And it actually allowed us to help localize our drainage to that particular area. So I think without a doubt, point-of-care ultrasound has benefits. There are some pitfalls that you need to be aware about. And for me, the main issues that I see emerging in this particular area are the training elements to this. What we must recognize is that we're not radiologists. We're certainly not interventional radiologists. And they clearly go through a huge amount of training. So especially in the countries that you practice, there might be, I would say, training considerations, training criteria that you have to fulfill before you can actually start doing lung ultrasound for diagnosing pleural effusions. But more importantly, I would say there is also a learning curve of using lung ultrasound when you're doing diagnostic parasynthesis or therapeutic taps. Now, how long and how you get that training over, but also when that training provides you competencies to be able to be confident with being able to perform the ultrasound in a way that you're able to do the procedure is something that is not defined in current evidence in neonatology. And I would say for me, it's taken years to learn. But what I would say is the actual diagnostic aspects of being able to diagnose lung conditions and pleural effusion is definitely evidenced. And I would say that from the current group of 35 people who we've been training, I'd say 25 of my colleagues are well on the way to achieving those competencies over a 3 to 6 month period. I think the reason I'm mentioning this is because depending on where you practice, there are certain medical legal requirements, not just training requirements, that mean that you have to be certified in the process. Now, the course that we currently run helps with certification of diagnosis of some of these procedures, but actually the training for this comes through simulated models, which we are currently producing and which I think in the next 6 months should be up and running. Now, how do we diagnose a pleural effusion on lung ultrasound? And I would say that of all the pathologies that you identify when you're trying to use lung ultrasound in neonatal practice, I think the diagnosis of pleural effusion is quite easy. I think the important thing from our perspective is being able to pattern recognize how it might look, but more importantly, how trying to quantify exactly how large it might be, where the pockets of collection are largest so that you're tapping in the right areas if you need to. But more importantly, there are certain signs. And what I'd say over here, I'm just going to demonstrate to you on a simple image using my laser pointer, that these are the ribs. This is the diaphragm. This, from our perspective, is the spleen. This is the left side of the chest. And really what you can see is compressive atelectasis of the lung here with a lingular kind of an appearance, which is basically what we call the jellyfish sign. But this entire anechoic area that you see in between is the pleural effusion. Now, if you can actually demonstrate this on an ultrasound, and if you needed to tap it, not only can you see this under direct ultrasound vision, you can actually then put a needle in the space where the pocket is maximum to ensure that you can drain this effusion if it's clinically necessary. But more importantly, what you can also see is you can gradually see the expansion of the lung as the fluid drains, which means that if you were doing a diagnostic parasynthesis using a needle butterfly, you can actually prevent a pneumothorax, because once your fluid comes to a point where the lung is expanded, what you really don't want to do is puncture this lung with the butterfly needle. I think in terms of being able to place drains, you want to place them in areas with the largest pockets to be able to maximize the therapeutic efficacy of the drain. And the beauty of the ultrasound is you can actually demonstrate those pockets using a transverse ultrasound technique that I will talk about today. More importantly, there are certain ultrasound signs which help and tell you, again, quantify how large an effusion might be. And this is M mode. And what I will demonstrate to you is what you can clearly see is what is called the Sinusoid sign, which is basically the flapping of this lung margin, the visceral pleura, in the anechoic fluid, which you see over here. But really, some lung ultrasound signs are very simple, and this is a very small effusion compared to the one that you see on the left. You can see the ribs over here giving their rib shadows with his lung that is visible over here. Now, for those of you who've never done lung ultrasound, take my word for it that you can see what is an A profile, which is well-aerated lung, with these vertical lines, which we call B lines. So what you've got is basically an AB profile. And this is, in essence, a baby who's got transitioning lung, most probably, with what has got a small effusion in between the ribs. It's not massive. And this quadrilateral triangle that, my apologies, rectangle that you see is actually what we know as a quad sign. And I will explain what it is. I think what is very important from our perspective is not only would you be able to tell and diagnose a pleural effusion, but what you can also do is diagnose lung pathology that you might see with an effusion. And this is a classical chest X-ray of a neonate, where you can see that the left lung and the right lung show a very ground glass kind of appearance. This is a preterm baby who's about 32 weeks of gestation with significant respiratory distress syndrome. On the ultrasound, what you see is basically a consolidation with static air bronchograms and lung that's basically falling away from the pleural line. A very small, minimal effusion is seen over there. Now, this is how sensitive lung ultrasound is that you can actually see the smallest of effusions in this particular kind of view. But more importantly, the underlying lung pathology, which at this particular point is most probably severe respiratory distress syndrome, if I correlate clinically with atelectasis. Now, clearly from my perspective, this is a baby who doesn't need a therapeutic parasynthesis. This baby basically needs intubation and surfactant, depending on the lung ultrasound scores. So again, lung ultrasound not only tells you the nature of the effusion, but also gives you a feel of the underlying lung pathology, which means that you can make therapeutic kind of decisions. I think the most important aspect for me when it comes to chronic effusions, especially effusions where they've previously been drains, and a good example is babies who have chylothoraces, often who might have drains right from the start, or exudative pleural effusions where they've had infective kind of changes. Well, these effusions can be septate, and an X-ray might not be able to delineate that as well. An ultrasound would, which kind of means that if you want to do, again, diagnostic or therapeutic parasynthesis, you can choose the area that you might want to. You might actually agree that it's probably not the wisest thing to do. But previously, CT was the only way to kind of evaluate this. And you can all agree that doing a CT would mean an element of transport if you do not have imaging in your neonatal unit, but more importantly, exposure to a large amount of radiation as compared to lung ultrasound, which can be done bedside quickly and in a very short period of time. So the benefits, I think, are very important. Now, what I'm going to do very quickly is just give you a flavor of how we diagnose pleural effusions and the different signs and their significance. And really, my intention today is just to give you a flavor. I wouldn't be able to go into the details of how you make a diagnosis, but really give you what I'd say is the element of pattern recognition that you need to have to diagnose it, but also give you a little bit more in terms of some important signs which might help to tell you the nature of the underlying effusion, in particular the Plankton and the Hematocrit sign. Now, I think as a basic kind of an approach, most of us, when we do our lung ultrasounds, we tend to use, I would say, longitudinal ultrasound, which is ultrasound, if you look at me, which is kind of perpendicular to the chest. And we would do it in all the zones. You'd do a comprehensive ultrasound. But the other methodology is what we call as transverse ultrasound, which is basically done in each intercostal space. Now, what you can see over here in the upper half of the image is a typical longitudinal ultrasound, which is being done, which has multiple ribs that you can see. You can see lung that is collapsed, which is visible over here. And really what you see in between is an anechoic area, which is quite dark. And this is the area of pleural effusion. Now, when I look at this particular image, a few things that I can see very clearly at this particular point are that it is completely anechoic. It does not have any debris inside it to the visible eye. There are no floating kind of I would say hyperechoic kind of lesions. There are no fibrant strands. I can clearly see the diaphragmatic margin. So the curtain sign is absent. I'll talk about that with the liver. So I can delineate in this image the maximum pocket. So if I was doing a transverse scan from above to below, and this was tailing off, really what I would like to do is go into the area of the maximum pocket if I was doing a therapeutic thoracentesis. More importantly, as I will show you in dynamic images, you can actually see the lung with a flapping tip, which is often called the jellyfish sign. Now, if you put an M mode over here, what is clearly visible is the flapping of the lung, which is the visceral pleura, while the parietal pleura, which is separated out with the rib margin, stays completely static. And that gives you this appearance on an M mode. So this is the anechoic pleural effusion. And really what you get is this movement of the visceral pleura, which basically gives you a kind of a wavy margin. And we call this the sinusoid sign. What is the Chord sign? So I'm just going to take my laser pointer off. So this is classically what we call a Chord sign. But what you can see again in this is a a longitudinal lung ultrasound that we're doing, where you can see the ribs that are visible over here with an intercostal space. You can see the parietal pleura over there. And really what you can see is visceral pleura with collapsed lung over here. In between, you have a large anechoic area that actually gives you a rectangular appearance with the ribs as the lateral borders and the parietal and visceral pleura as the superior and inferior borders. And this kind of quadrilateral rectangular appearance is what we call the Chord sign. You can see the lung move. And classically, if I was to put an M mode here, the flapping of the visceral pleura would clearly give me what I call a sinusoid sign. So again, these are the ribs. These are the rib shadows that you can see, which form the lateral borders of the quadrilateral. And really, these are the superior and inferior borders, which are basically formed by the parietal pleura, the intercostal space, the inferior margin basically being formed by the visceral pleura. Now, if you can see this in this particular area, then you can see the area where the Chord sign is maximally placed. That usually is your area of maximum effusion. Again, just a flavor of how we trace a pleural effusion when you're doing a longitudinal scan. So you move from above below, and as we know, if you have a baby that's supine, the pleural effusion will tend to accumulate, if you look at me, in the posterolateral aspects of the chest. So often what you'd be doing is keeping your ultrasound probe longitudinally in the posterolateral aspects of the chest, moving from above below. And what you'd be able to then quantify is the effusion as you move from above to below. But classically, what you can see is ribs, which are visible over here and over here with the intercostal space. And I can see a rib over here. But you can then see this area of atelectatic collapsed lung. We call this compressive atelectasis because the fluid has basically caused the lung to kind of fall away from the parietal pleural margin because of the anechoic fluid in between. Again, when I look at this fluid, I can't see any debris. I can't see any particles. I can't see any fibrin strands. It's dark. It's anechoic. What I can clearly see is a margin of the diaphragm, which is clearly visible over here, right to the costophrenic angle, which basically gives me a triangular shape. And below that, I can see the spleen. Now, the benefit of being able to get this view is I know exactly where my abdominal viscera is. And if for any reason I want to drain this effusion and I want to drain it under ultrasound guidance, really going into the intercostal space means I can avoid puncturing this organ, both on the right and the left. On the right, the liver, on the left, the spleen. Classically, this rectangular appearance that I've talked about, the quadrilateral, is what we call as the Chord sign. And again, as I said, parietal visceral pleura with the rib shadows on the left. So something that is very easily seen and not difficult to learn. Going to my next slide, just giving you a flavor of the sinusoid sign. And again, what I would say from my perspective is that when you look at the sinusoid sign, the sign is basically produced on M mode. So this is the Chord sign, as you can clearly see with the arrows. But when I put my M mode, pretty much just at the level of, I would say, the visceral pleura, the lung flapping of the visceral pleura basically creates a margin, from my perspective, which is quite wavy. You clearly have an anechoic area, which is visible over here on the M mode. And then because there's, I would say, parietal pleura with rib margin, which is completely static, as you can see in this image, you see what looks like basically what we'd say is a part of the seashore. And that's clearly seen in this particular image. So a very nice demonstration of the sinusoid sign. Just going to my next slide. So that's the sinusoid sign, as you can see, the wavy margin of the visceral pleura. Now, one of the signs that I would say is very, very important to try and diagnose small pleural effusions is what we call the curtain sign. Now, this is the left side of, sorry, my apologies, the right side of the chest as seen on an ultrasound. And what you can see is the ribs with well-aerated lung, and you can see a diaphragmatic margin. Now on chest X-ray, often the costophrenic angle, if you have no fluid, will be completely loosened. It will not actually be obliterated. A pleural effusion on a chest X-ray would actually obliterate this costophrenic angle. On the other hand, if you look at an ultrasound, normal movement of the lung will actually cause the lung, which looks aerated in this particular image, to obscure the lateral margin of the diaphragm. So when you look at the diaphragm here, this is the medial margin of the diaphragm. This is the liver. And actually, when you try to look at the lateral margin of the diaphragm, what you'll find is that it is completely obscured because of this lung as it expands. And this is what we call the curtain sign. So the curtain is this aerated area of lung which overlaps the liver, which basically causes the lateral margin of the diaphragm to disappear completely. Now, if you have a small pleural effusion, as I will demonstrate with the image on the right, then what happens is the costophrenic angle gets filled with fluid. And really, this costophrenic angle highlights the lateral margin of the diaphragm that you can see over here. And this is called an abnormal or an absent curtain sign. Now, clearly, you can quantify and see, and this is a very small effusion, but actually, this is a significant effusion where you can actually see the lateral margin of the diaphragm in its entirety. Now, as it gets larger and larger, often what you see is this appearance here, where actually the diaphragm is not just outlined, but the lung has compressive atelectasis, and it floats in the pleural fluid. And when it floats in the pleural fluid, its distal margin basically produces a flapping kind of a sign that you can see over here, which is akin to a jellyfish. moving in water. And this is classically known as the jellyfish sign. But really, when you're trying to locate collapsed lung and the distal margin of the lung in the distal most recess, really what you're really trying to locate is the jellyfish sign. And just remember that the lung, especially if you have underlying consolidation, can collapse and show atelectasis in different ways. And it can be quite irregular, especially if you have mnemonic kind of consolidation, which means you might see multiple such areas. What you're really looking for if you ever want to do a diagnostic or a therapeutic parasynthesis is really the area, the largest recess with the largest amount of fluid to tap so that you can actually protect the lung from being punctured. Now, for those of you who do lung ultrasound, what you can also see in this image is static air bronchograms, which again fit with atelectasis. But if you start seeing dynamic air bronchograms in this image, and with the eye of faith, I can see one area of what I call a dynamic air bronchogram, where the bronchogram is disappearing and appearing, again, which says to me this could be a mnemonic consolidation. So again, what I'm highlighting to you is not just the fact that you can diagnose a pleural effusion, but you can actually get an idea of underlying lung condition and lung disease. What I would advise is that you must clinically correlate. And I can't emphasize this enough because underlying lung disease, there are a large number of features, as we've seen in our course over the past 3 months, which overlap. And compressive atelectasis with static air bronchograms might just be lung that's atelectasis because of fluid, as opposed to mnemonic consolidation. But if you see dynamic air bronchograms, which appear and disappear, as you can see in this small margin over here, then it raises the possibility of this being air bronchograms moving in and out, which are more commonly seen with pneumonia. Now, if I clearly have a CRP of 50, 60, and I've got a baby that looks toxic, then from my perspective, I'd really be thinking about whether this might be a mnemonic consolidation. And then as I'll describe to you, if you can actually see debris within it, it becomes an exudate. Now, just another example of underlying lung condition. And this is a baby who basically, from our perspective, has got compressive atelectasis. Again, this is a longitudinal scan. And what you can clearly see is the costophrenic angle. You can see an abnormal curtain sign because I can see the lateral part of the diaphragm there. I can see a quad sign that's clearly visible over here. But what I've got is compressive atelectasis of the lung. Not only do I have compressive atelectasis of the lung, I've got lung consolidation with air bronchograms and fluid bronchograms. So these bright areas that I actually look at, which are linear, actually are static air bronchograms. And then there are small areas of bronchograms that are moving in and out that you can see over here that I'm going to highlight with my pointer. You can see them in this region over here. They appear, disappear. Appear, disappear. Appear, disappear. These are dynamic bronchograms, air bronchograms. And these dark areas that you see in between, they're actually fluid bronchograms. Now, this is a baby who had previously had a chylothorax with a chest drain inserted, where we had started feeds, and there was accumulation of an effusion. But more importantly, from our perspective, this baby had started to get severe respiratory distress, had become febrile. And in this particular situation, when we did bloods, we had a very high CRP. What you're clearly seeing is lung over here that looks very much like a liver consistency, and this is called a tissue sign. And all these signs together often give us the feel of what we call as a mnemonic consolidation. This baby was treated for what was basically compressive atelectasis, and we did a diagnostic parasynthesis, which basically had a very high cell count, predominantly neutrophils, which meant that we thought this was probably a mnemonic kind of a collection. We had no evidence of chyle in this. We had no lymphocytes, few lymphocytes actually, but very high protein. So again, the benefits of being able to do ultrasound of the lung are you can actually look at the underlying lung, and if you clinically correlate, it gives you a feel of the tissue. And as you can see, the lung here looks very much liver-like. So this is what we call as a tissue sign. What is the spine sign? Now, the spine sign is a sign which is usually seen when you have very large pleural effusions. And the reason you're able to see them is because we know that fluid basically provides a very good acoustic window for sound waves to go through. So if your probe is kept at the top, as it would be kept over here, then really sound waves would be moving in, they'd hit the ribs, and actually you'd get these acoustic shadows. Now, obviously, fluid from our perspective gives you an anechoic kind of an appearance, but it's able to allow transmission of sound waves as compared to air, which means that the distal tissue, which obviously has a different density to the fluid, and what we know is that if you have significant differences between the acoustic impedance of a particular region, which would be this margin here, where you have fluid and tissue interface, then those areas at the level of the interface then appear hyperechoic or bright because of reflection of the sound waves back. So actually, when you have a significant amount of fluid, sometimes what happens is the posterior margin of the spine gets highlighted. And this is classically known as the spine sign, as can be seen in this image as well. It's usually indicative that the effusion is quite large. Now, we've talked through the different signs that we have, but there are some signs that can also give you an idea as to the nature of the effusion. And what I would say is that they're not set in stone. And I would especially emphasize that in neonatology and with neonates, you have to be extremely careful. I have been in situations where I have seen debris in pleural fluid. I've seen fibrine strands, what I think are fibrine strands. And actually, when you tap it, you get what is a biochemical kind of pattern, which is consistent with transudate. So I think clinical correlation is important. I'd also say that if you're looking at trying to differentiate transudate, exudate, in particular syndemonic kind of effusions, it's very, very important from our perspective that when you do a diagnostic parasynthesis, that you, in addition to the ultrasound features, are actually looking at the biochemistry, the underlying cell counts, and making that diagnosis. I would be very cautious with trying to diagnose hemorrhagic pleural effusions. One of the challenges in extremely small babies is if you try to tap effusions, or I would say, in particular with preterm babies and high drops, you can end up injuring or puncturing the lungs, the intercostal vessels, and often for that reason, you can actually get hemorrhagic kind of appearance to the fluid, which might mean that while it appears completely anechoic, you get blood, and that's why you think it's hemorrhagic. So again, it's really important that you are clinically correlating, but yes, there are some signs, and one of them is the Plankton sign. And the Plankton sign is a sign which basically demonstrates the presence of echogenic particle-like, I would say, densities that you see in the pleural fluid. And because of their size and the way they float, they look like plankton in the ocean. And as you can see over here, you can see clearly plankton, like echogenic, hyper intense particles that are floating within this pleural effusion. You can see collapsed lung over here, which actually looks to be quite septate in a way, some of the fluid areas around it. And actually some elements of fibrin strands are also seen. Now, this would be highly indicative of an exudative kind of effusion. Now, if you had a CRP of about 200 with a baby that's febrile and toxic, and you aspirated and you got fluid that looks pus-like, then really it would not be surprising if you saw this kind of ultrasound appearance. You can see a similar kind of an ultrasound appearance again if you have a very high hemorrhagic kind of a pleural effusion, and these could actually be RBCs as well. So again, the Plankton sign is not pathognomonic for a mnemonic or a syndemonic or an exudative kind of an effusion. It might actually indicate a hemorrhagic component to the effusion as well. But it's a sign that usually is indicative of an exudative kind of an effusion. The second sign that has been described generally in relation to hemothorax is really the hematocrit sign. And often it happens when you've had hemorrhage into the pleural fluid. That might be because you've punctured the ipsilateral lung and you've had a hemothorax, but really the dense RBCs tend to accumulate in the most dependent areas of the lung. And this is an ultrasound in an adult who's actually, I would say, not supine, but actually erect. So what has happened is that the RBCs have settled down and they give you this difference in density as compared to the anechoic component of the effusion, which we classically call the hematocrit sign. I must confess it's not something that I've seen in a neonate, but it's described in the literature and I wanted to give you a flavor of it. I think what is well described in neonates, in particular in neonates who might have had multiple chest drains or might have effusions that are chronic or a septate, are the presence of large fibrin strands, which could result in septate or actually loculation, but more importantly can be seen floating within the pleural effusion. Sometimes they're dense enough to actually look like large debris, as you can see on the left-hand side. And this is a baby who's basically had very thick, dense chyle. It's an antenatally diagnosed chylothorax. And what you can see, again, is the ribs, the intercostal space. You can see a classical Chord sign, the visceral pleura with the lung beneath that, again, which basically shows compressive atelectasis, some static air bronchograms. A classical, I would say, B profile is the way we would describe it. And you can see this density in between, this hyperechogenic material, which actually, when we tapped, we got a very chylous appearance to this. Baby was on feeds. Now, septate pleural effusions, as you can see, can be diagnosed on the ultrasound and may be very difficult to diagnose on chest X-ray. But again, importantly from our perspective, need a great deal of caution if you're deciding to do a therapeutic parasynthesis. In particular, trying to differentiate what might be lung versus what might be effusion can be incredibly challenging. And really, these are kind of situations where having a diagnostic or an interventional radiologist, if you want to do a tap or treat or place a drain, can be hugely beneficial. Because if you have large areas of pocketed collections which are causing compressive atelectasis and symptoms in neonates, and I've been in that exact situation with a baby in Southampton, where we had evidence of what was a complete whiteout on one side, but where we placed a drain based on landmark-based, I would say, guidance in the 6th intercostal space and posterior axillary line, and actually ended up with very little fluid, virtually a dry tap, which was very surprising for us considering we had significant mediastinal shift in a baby where we clinically correlate. We think we should get a large amount of fluid. And actually getting the radiologist to come in and tell us that actually it was the superior area of the lung which had the pocket and that our drain should go in there really was hugely beneficial in being able to diagnose and treat that baby. Now, I'm just presenting to you a case, again, of a term baby, a baby with a tracheoesophageal fistula. This was a baby who was diagnosed postnatally and had a postoperative repair because there was not much of a gap on day 4 of life. So had an end-to-end anastomosis and actually clinically extubated on day 6 onto some Optiflow and was in air by day 9. So I would say a pretty good outcome for a baby with a postnatally diagnosed tracheoesophageal fistula. Feeds were started and increased with EBM and formula. And by day 17 of life, this baby was tolerating full feeds. But what we noticed on day 23 was increased work of breathing with reduced right-sided air entry. And really what we had in a baby who was gradually going into higher oxygen requirements was an extremely large collection. And this is not a longitudinal, this is a transverse scan, but this is a transverse scan in the area of the largest pocket of pleural effusion. And really what I'm showing you at this particular point is a diagnostic and therapeutic parasynthesis that we did. So what you've got is lung, which is collapsed over here. You've got some echogenic material with a large pleural collection, which is quite anechoic. And what you can see is a needle going in for basically a diagnostic parasynthesis where we're also doing a therapeutic tap. And as we aspirate fluid, which is done under direct vision, what you can see is we can see the lung expand to the point where we stop, but you can see again the needle just there. And I think this is one of the benefits if you're using a butterfly to be able to do diagnostic and therapeutic parasynthesis, is that you can drain the effusion under direct visualized guidance. Now, this is a transverse scan in the intercostal space, collapsed lung with a large hyperechoic area, anechoic, hypoechoic area, again, a little bit of debris in a baby who's got what is a large collection. Now, if you want to tap this, you can tap it under ultrasound guidance and you can aspirate the fluid. Now, in our baby, we aspirated the fluid, and clearly we ended up still with a small pneumothorax on the right side, probably because the needle hit the lung. And this is also one of the benefits of using lung ultrasound, is that you can actually diagnose a pneumothorax if it does happen, and really quantify by lateral migration of your probe how large that pneumothorax might be and whether really you need to drain it or not. Now, how do we perform diagnostic parasynthesis using an ultrasound? So for us, the baby should always be supine, usually elevated with a towel underneath, and I usually keep the baby elevated. So you confirm site, you confirm baby, you go through what I call is a timeout procedure, drape and use your aseptic technique. For a landmark-based parasynthesis, the triangle of safety is usually the third to fifth intercostal space and mid to posterior axillary line. The benefit that ultrasound gives you is you can see the largest pockets in the baby, even when the baby's supine, and you can actually demarcate where the liver is. So if you did want to go into the sixth space, with a lot of people feel quite uncomfortable doing because you're worried you'll hit the liver, then you can actually do that if you do that by detecting that pocket using an ultrasound. The idea from our perspective is that you would use a transverse ultrasound, as you can see me do, in the posterior lateral areas of the chest, going down to basically quantify the largest pocket of ultrasound and then mark that area for your insertion of the drain. But more importantly, what I also like to do is try and quantify where I think the liver might be in relation to that, so that I'm 100% that I'm actually not going to hit that. You can then keep the probe there, aspirate, and watch the effusion improve. So again, there are huge advantages of being able to do the procedure. Now, this is clearly a situation where I've got a decent pocket, and actually, in a symptomatic baby, if I had to drain this, I know where I have to go and what I have to do. But this is clearly a baby who's got a very small area of pleural effusion. Now, if this baby had severe respiratory distress, my argument would be, well, it's unlikely to be the pleural effusion. And the real risk is that if you end up tapping something like this, you would probably end up puncturing the lung and create a pneumothorax. So again, the ability to be able to quantify a pleural effusion, and this is a transverse scan in the intercostal space, which shows a very small amount of pleural effusion with compressive atelectasis, slightly irregular pleural visceral line with what is classically a B profile with multiple B lines which have coalesced together. Now, this, from my perspective, if you clinically correlate, is an effusion where I would really be thinking about why this baby has respiratory distress, unlikely to be the effusion in this particular situation. Just another example of the classical Chord sign. As you can see more than one jellyfish here with the way there's been compressive atelectasis. You can see an abnormal curtain sign, which is absent because I can define the diaphragmatic margin really nicely. And if I put M mode in this particular region, then really what I would get is a sinusoid sign. So just, it's quite clear. We've already seen this image. And again, it just gives us an idea about the underlying lung and how it helps with diagnosis. But this is a diagnostic parasynthesis before and after. And clearly, from my perspective, I've done it and I've tapped, but without wanting the lung to kind of come completely to the margin to avoid puncturing the lung. So again, it's really safe to be able to do a diagnostic butterfly parasynthesis without puncturing the lung, because you can actually monitor the volume of fluid in the lung appearance. Very similar kind of appearances where we've done a diagnostic parasynthesis, and clearly what you can see is, you stop once the lung margin comes really close to avoid puncturing the lung. But if you do puncture the lung, then lung ultrasound is hugely beneficial in that what you can clearly see from our perspective is a classical seashore sign here in a baby who's got pleura, which is sliding with a B profile. So there's no evidence of a pneumothorax here. But actually, when I look at the image on the right, I can see no lung sliding in a baby who's got horizontal lines, which we call A lines, with a classical barcode sign. So actually, if I did puncture the lung, I can do an ultrasound immediately to diagnose that pneumothorax. Can you imagine the number of x-rays you'd have to do if you were doing a diagnostic parasynthesis before and after? And then if the baby deteriorated and you had to diagnose the pneumothorax, you'd probably try and transilluminate. If it's very small, it may be negative. But really, a lung ultrasound has a very high sensitivity for diagnosing even small pneumothoraces. And what you can see on the left is normal lung with good sliding and a B profile. But on the right, there's a classical A profile with a pneumothorax. So coming to my last slide. So there are formulas which help you to quantify the volume of pneumothoraces. And the formula that is, I would say, closest to how we should be practicing in neonates is Ballick's formula, because neonates are classically kept supine. And when they're kept in supine position, really from our perspective, what we're trying to do is measure the volume of the effusion. Now, when you're measuring the volume of the effusion, what you're doing is you're not doing uh, longitudinal scans. You're doing what I call a transverse scans in each intercostal space. And you're coming in each intercostal space. And as you know, the posterior lateral aspects, uh, usually at the bottom, will be the area of maximum collection. But once you see that area of maximum collection, what you're doing is measuring the distance from the atelectatic visceral pleura to the margin there. And if you measure that margin in millimeters and multiply that by 20, that gives you the volume of the pleural effusion in mils. There are no studies, to the best of my knowledge, that actually replicate this process in neonates, but I would say the formula, with some element of plausibility, can be used. I think what I'd say is fairly obvious is quantifying a large pleural effusion is not difficult. I think what I would say is you need to clinically correlate as well. And as all these images show, you can quantify a large from a small pleural effusion quite easily. So I think that brings me to the kind of end of the talk. And what I would like to say to you is that there's absolutely no doubt in my mind that lung ultrasound per se is a very important aspect of our arsenal for evaluating the lungs, not just with regards to pleural effusions, but with regards to the diagnosis of a large number of other conditions. We run a 3-month course on this. The next course will be in January. If any of you is interested in enrolling in it, what we recommend is that you get consent from your institute to be able to anonymize and share images with us, with a view to trying to get critique of those images. Now, we have a guidance and a guideline which basically says that you have to fulfill a certain number of images to achieve levels of competency. But the level of competency that we would leave you with at the end of 3 months, if you're able to demonstrate that you've been able to do a minimum of 5 scans as L2, if you're able to identify all pathologies, I would say you become L3. And really, at the end of the course, we have an exam which you have to pass in order to complete your L3 competencies. But the idea from our perspective is we accredit and we certify your skills, provided you've been able to do those demonstrations. Clearly, from our perspective, things are moving forwards, and in due course, we will have 2 simulators on which we'll be able to teach you not just lung ultrasound, but a lot of point of care ultrasound as well. So if anybody is interested, feel free to contact me. I am the director for the MPROvE Academy. If you Google us, you will be able to find us. Very quickly, in the interest of time, as it is, well, we have 5 minutes, as I intended this to be an hour. So does anybody have any questions? You can raise your hands in the chat box, and I will enable you to be able to chat. Nobody with questions? Nobody with questions? I always like a question. Okay, so we have a hand raised, which is great. So Kirti, you can talk now. You'll have to unmute yourself.
Hi. My question is that if we don't use this Balic formula, and if we're keeping the probe longitudinal like we usually do, and we have the depth on the side saying 1 centimeter or 2 centimeter, is there no other way to quantify the pleural effusion?
What I'd say is that you're quantifying it in centimeters, and really what it will be able to give you is trend analysis. But in terms of kind of being able to tell you what the volume is, I use the Balik's formula. I tend not to use the centimeters, and the reason for that, again, that I would caution you against is most of our babies are supine, but depending on how you keep them, especially if you put a towel below, you can then have problems with estimating it. The Balik's formula is specifically to try and estimate volume as opposed to the maximum area of, like small changes in position. And if the baby's slightly tilted, might actually give you a very large difference in terms of centimeters of how you're evaluating that. So the position of your baby is quite crucial.
So in this formula, the length that we are multiplying by 20 has to be in centimeters, is it?
Millimeters.
Millimeters.
It's in millimeters as measured. So if you had a marking in centimeters, you basically multiply that by 10 and then multiply by 20.
Okay, thank you.
You're most welcome. I have Dr. Hassoun, who I will enable. Actually, he is, yeah. So Dr. Hassoun, please go ahead. You'll have to unmute yourself.
Am I audible? I think, yes.
You are audible, yes.
Yes. Just, Alok, thank you very much for this presentation. But just if you have for the next session, if we can have some example of meconium aspiration syndrome. So I think I have a gap in, I didn't view, did ultrasound for this kind of babies, especially after intubation.
No problems. Absolutely fine. Happy to share that with you. So I have a question from Suman Charasia. Where does the factor of 20 come from? It comes from Balik's study, which I will share with you, which is a study on, I think it's about 119 adults and children, where he basically quantified pleural effusions using this methodology with a standard structure. I'll be sharing the video with our learning group as well about how you do it. But really, he was able to quantify that using a comparative method to be able to develop the formula. I'll share the article with you so you can read the exact methodology of it. I am really grateful, everybody. I'm grateful for the fact that you've given up an hour of your weekend to share time with us. But again, I hope you all enjoyed the talk. And for my colleagues who are learning with us, we have 2 more sessions. Any cases that you'd like to discuss, any gaps, any areas that you feel we've not covered, please WhatsApp me and I will be talking about it with the next 2 talks, which will be Thursday and Sunday. I hope you all have a good day.